Pericarditis on an ECG is characterized by concave ST elevation, often with a saddleback appearance in multiple leads and associated PR segment depression. The Spodek sign, a downward-sloping TP segment, is specific for acute pericarditis. Benign early repolarization, or BER, is a normal ECG variant. It presents with mild ST elevation and tall T waves, often with a characteristic fishhook pattern, which is a notch at the J-point. It is not a pathological condition. Left ventricular hypertrophy, or LVH ECG findings, include left axis deviation due to increased muscle mass. Key changes involve deep S waves and ST elevation in V1, V3, along with the strain pattern of ST depression and T wave inversion in lateral leads V5, V6. Ventricular aneurysm, typically after a prior MI, is diagnosed on an ECG by a triad of persistent ST elevation, deep Q waves, and inverted T waves in leads V1, V3. Brugada syndrome is an inherited sodium channel disorder causing arrhythmias. The characteristic Brugada sign shows ST elevation and a partial right bundle branch block in V1, V2 with a distinct COVID morphology. Raised intracranial pressure from traumatic brain injury or intracranial hemorrhage can present with cerebral T waves, which are widespread, deep T wave inversions. Widespread, concave ST elevation may also be observed. Takotsubo cardiomyopathy, or broken heart syndrome, is often triggered by severe emotional distress. ECG changes commonly include new ST elevation or T wave inversion, and moderate troponin rise is frequently observed. J waves, or Osborn waves, in hypothermia can simulate ST elevation. These positive deflections at the J-point, most prominent in precordial leads V2, V5, and their height is proportional to the severity of hypothermia. ST segment depression morphology can be upsloping, which is often normal during exercise. Downsloping depression is highly suggestive of ischemia or strain. Horizontal depression is strongly associated with myocardial ischemia. Reciprocal changes show ST elevation in one area, such as lead 3, with reciprocal depression in an opposing area, like AVL. Posterior MI often presents with ST depression and prominent R waves in anterior leads, V1, V3. Key criteria for posterior myocardial infarction include horizontal ST depression, dominant R waves, and upright T waves in V1, V3. Confirmatory ST elevation is seen in posterior leads, V7, V9. De Winter T waves are considered a STEMI equivalent. Their morphology is characterized by upsloping ST depression and symmetrically peaked T waves in precordial leads, highly specific for acute LAD occlusion. The digoxin effect results in a distinct, predictable ECG pattern. This includes downsloping, sagging ST depression, also known as the reverse tick appearance, and a relative shortening of the QT interval, most prominent in lateral leads. Hypokalemia causes characteristic ECG changes, including widespread downsloping ST depression, T-wave flattening or inversion, and prominent U waves. A prolonged QU interval is also a typical finding. Right ventricular hypertrophy, or RVH, is characterized by prominent ST segment depression and T-wave inversion. These changes are primarily observed in the right precordial leads, V1, V3. Supraventricular tachycardia, or SVT, commonly causes widespread horizontal ST depression, which is most prominent in left precordial leads V4, 6. This rate-related depression does not necessarily indicate ischemia. The T wave represents ventricular repolarization. It is normally upright in all leads except AVR and V1. The amplitude is typically less than 5 mm in limb leads and 10 mm in precordial leads. Its duration is related to the QT interval. T-wave abnormalities include peaked T waves, often seen in hyperkalemia. Hyperacute T waves are broad and asymmetrical, an early sign of STEMI. Inverted T waves can indicate ischemia or ventricular hypertrophy. Peaked T waves are tall, narrow, and symmetrical, characteristically seen in hyperkalemia. Pathophysiologically, this is due to increased extracellular potassium-enhancing potassium conductance, leading to faster phase 3 repolarization. Hyperacute T waves are broad, asymmetrically peaked T waves, and are a critical early indicator of myocardial distress, typically seen in the early stages of ST elevation MI. They often precede ST elevation and Q waves. Inverted T waves can be physiological or functional, such as a normal finding in children or secondary to bundle branch block. Pathological causes include ischemia, pulmonary embolism, and hypertrophic cardiomyopathy. Clinical correlation is essential. In children, inverted T waves in the right precordial leads V1-3 are a normal finding known as the juvenile T wave pattern. This represents the dominance of right ventricular forces and should resolve as the child matures. T-wave inversion in myocardial ischemia and infarction occurs in contiguous leads based on the affected wall. For example, inferior wall involvement shows inversions in leads 2, 3, and AVF. Left bundle branch block produces T-wave inversion as a secondary repolarization abnormality in the lateral leads, specifically I, AVL, V5, and V6. Right bundle branch block is a common finding that causes T-wave inversion in the right precordial leads V1 through V3. Hypertrophic cardiomyopathy often features deep T-wave inversion across all precordial leads due to the thickened heart muscle impacting electrical activity. Biphasic T-waves can indicate critical conditions. In ischemia, T-waves go up, then down. In hypokalemia, the pattern is down, then up. Whelan syndrome, defined by inverted or biphasic T-waves in V2-3, is highly specific for critical stenosis of the left anterior descending artery. There are two types, type A, biphasic, and type B, inverted. The camel hump or double peak T-wave can be caused by severe hypokalemia, where prominent U-waves create a double peak effect, or by sinus tachycardia, where P-waves hide within the T-wave. Flattened T-waves are a non-specific finding, but may indicate ischemia, especially if dynamic, or electrolyte abnormalities like hypokalemia if generalized. The QT interval is the time from the start of the Q-wave to the end of the T-wave. Clinically, it represents ventricular depolarization and repolarization. Normal corrected QT or QTC values are typically less than 450 milliseconds for men and 460 milliseconds for women. The QT interval is inversely proportional to heart rate. A faster heart rate shortens the interval, while a slower rate lengthens it. A prolonged QT carries an increased risk of ventricular arrhythmias, such as torsades de pointe. Prolonged QTC, defined as over 440 milliseconds, can be caused by electrolyte disturbances like hypokalemia, cardiac issues like myocardial ischemia, and systemic problems such as hypothermia. A wide variety of medications can also prolong the QT interval. Hypokalemia causes an apparent QTC prolongation due to TU wave fusion in the limb leads and prominent U waves in the precordial leads. This phenomenon can complicate the accurate measurement of the true QT interval. Hypomagnesemia is a key electrolyte disturbance that significantly contributes to QTC prolongation. It frequently coexists with hypokalemia and increases the risk of malignant arrhythmias like torsades de pointe. Hypocalcemia typically prolongs the ST segment, while the T wave remains unchanged. This results in an overall lengthening of the QT interval, contributing to the risk of arrhythmias. Severe hypothermia can cause marked QTC prolongation. It is often accompanied by slow atrial fibrillation, Osborn waves, and shivering artifacts, which can interfere with the ECG trace. Myocardial ischemia usually produces a modest increase in the QTC, typically in the 450 to 500 millisecond range. This can help differentiate hyperacute MI from benign early repolarization, which typically has a normal QTC. Congenital long QT syndrome is an inherited disorder affecting ion channels that leads to prolonged QTC. This condition is associated with a high risk of torsades de pointe and sudden cardiac death. Causes of a short QTC, less than 350 milliseconds, include hypercalcemia, congenital short QT syndrome, and the characteristic digoxin effect on the ECG. Hypercalcemia leads to a shortening of the ST segment, which effectively reduces the total QT interval. This electrolyte abnormality may also be associated with the appearance of Osborn waves. Congenital short QT syndrome, or SQTS, is an autosomal dominant inherited disorder of potassium channels. Key ECG features include a very short QTC, often below 300 milliseconds, and tall, peaked T waves. The Osborn wave, or J wave, is a positive deflection at the J point, often seen in hypothermia. Other potential causes include hypercalcemia, myocardial ischemia, and various neurological or cardiac conditions. This video has covered key ECG findings for ST segment, T wave, and QT interval abnormalities, including both benign variants and critical pathological conditions. Accurate interpretation of these findings is essential for clinical decision-making.